All right. Hi, everyone. Welcome back. This is the Insights podcast. As you remember, Insights is based on the incredible content that's on Call, which is a continually updated online chapter textbook that is published by the Neurocritical Care Society. And today I'm back with Salia. We have a really exciting episode because subarachnoid is an exciting topic, but also there are two new guidelines to inform this updated content. And we're really excited to dive right back in. But before we get started, a couple words from our sponsor, Biogen and Cerebell, and now a word from one of the sponsors.
Founded in 1978, Biogen is a leading global biotechnology company that has pioneered multiple breakthrough innovations, including a broad portfolio of medicines to treat multiple sclerosis, the first approved treatment for spinal muscular atrophy, and two co-developed treatments to address a defining pathology of Alzheimer's disease. Biogen is advancing a pipeline of potential novel therapies across neurology, neuropsychiatry, specialized immunology, and rare diseases, and remains acutely focused on its purpose of serving humanity through science while advancing a healthier, more sustainable, and equitable world.
All right. So, just like I said in the intro, this has been really exciting because there's not one, there are two recently updated guidelines. One has been put forth by the Neurocritical Care Society, and then one is by the American Heart Association, the American Stroke Association, and now the On Call chapter reflects these updated management paradigms. And so, this has been a really exciting content update. The last time we had really a whole new set of guidelines had been over 12 years ago. So this is fresh management.
Awesome. Yeah. Hi, everyone. Thank you, Casey. It's good to be back. As you said, this is really exciting. It's exciting enough that we're going to do two different episodes on it. The first one will really focus on, what we're going to do in the acute phase and just stabilizing these patients. Let's say you get them in the ED, just the initial assessment, initial management. And then the second episode that we're going to do together also is going to focus on, okay, now these patients are diagnosed and they're going to have some complications, and how do we go about those complications and management of those complications. So, Casey, let's say you get a call to go see someone in the ED. When do you actually think about subarachnoid hemorrhage? How do you assess these patients, and when does that seem to be your initial first thought for diagnosing these patients?
Absolutely. So I think the hallmark trait of these patients is that these are patients who present with the worst headache of life, classically. Now, it is really important to remember that subarachnoid hemorrhage is not the only thing that causes an abrupt onset headache. You also have to consider, is this reversible vasoconstriction syndrome? Is this meningitis? Is this pituitary apoplexy? Even interparenchymal hemorrhage can cause that terrible onset headache. So when I hear someone say, this was a person who came in worst headache of life, then of course my suspicion is, to rule out subarachnoid hemorrhage. And what I think the guidelines have made really clear is that our threshold for scanning people with new onset worst headache of life should be very low. The American Stroke Association guidelines talk about the Ottawa imaging rule for subarachnoid hemorrhage. Going through the details of that is really not important, other than to say that it's like very sensitive. Basically, anyone who's coming in with a thunderclap headache needs imaging with a non-con head CT to evaluate for whether or not they've had a subarachnoid hemorrhage. The CT scan, good, up-to-date CT scanners are very, very sensitive at picking up acute blood. The acuter the blood, the more sensitive they are. As time goes on, the sensitivity of a CT scan diminishes. And so one of the things that I think is very interesting in this guideline is they talk about sort of the 6-hour divide between the patients who come in within 6 hours of the ictus of headache and those who come in after 6 hours. For the patients who come in within 6 hours, if there is no sign of subarachnoid hemorrhage on a CT scan that's on a high quality scanner, the scan is read by a neuroradiology trained radiologist, then that's it. You're done. That patient doesn't have subarachnoid hemorrhage. It gets a little trickier if they are coming in after 6 hours of the ictus of headache. At the after 6 hour mark, that's CT scan. If there's any equipoise and clinically you have a high concern because the patient says, I'm really having a bad headache. It came on all of a sudden. It was worse right when it started. Unfortunately, you really do need to do a lumbar puncture to rule out xanthochromia. Now, one of the things that I think we were hoping maybe we could get away with is MRI. And one of the things to make clear is that the ASA guidelines say there is not enough data on the use of MRI in these patients. So we cannot rely on an MRI to be the next step in our diagnostic algorithm for subarachnoid hemorrhage. You have clinical concerns. It's been more than 6 hours. There's equipoise on the CT scan. That patient needs a lumbar puncture. When you find subarachnoid hemorrhage on the CT scan, it's first of all really important to look at the pattern of subarachnoid hemorrhage. I think we're all trained to be focused on subarachnoid hemorrhage means that there's an aneurysm has ruptured. That pattern of blood is usually blood within the basal cisterns, kind of at the base of the brain, which is where the circle of Willis is. So when these aneurysm ruptures, they put blood into the circle of Willis, into the ventricle space. That's sort of the classic pattern. Cortical subarachnoid hemorrhage actually has a different differential diagnosis. We're not going to talk about that during this, but it is kind of important if you're trying to tease out, is this an aneurysm rupture patient, that you're looking for sort of the classic aneurysm rupture pattern, or sometimes blood in the Sylvian fissure, which can be sort of an atypical pattern. All right, but let's say this is a patient. They come in, it's within 6 hours. They've got blood in the bit and the basal cisterns. This looks extremely concerning for for an aneurysmal subarachnoid hemorrhage. Really, really important to get the patient to a high volume center. We know that dedicated neurocritical care and neurovascular surgical expertise make a big difference in these patients. So the first step, if you're not sort of at a high volume subarachnoid hemorrhage center, is getting the patient to one of those centers. And then we're also thinking through kind of the top 3 things that can make these patients worse acutely. So they absolutely need their aneurysm treated as soon as possible to prevent one of the worst complications, which is re-rupture. They also really need early treatment or even sometimes prevention of hydrocephalus. Remember that when blood from an aneurysm ruptures, it's rupturing into the CSF space. It's causing that CSF to not circulate in the way that it normally would. And that leads to the development of hydrocephalus. This is what can really kill people. If they don't die from the aneurysm rupture, they can die because of hydrocephalus. And that is a completely treatable etiology. So we need to get them to a place where a neurosurgeon can put in an external ventricular drain or a lumbar drain, depending on kind of how your center manages these patients. I think there's still some equipoise there about which way is better. Either way, they're going to need CSF diversion. And then we have to think about, well, what are some of the things that can make re-rupture more likely? And how do we prevent those things? And the 2 things that come to my mind are seizures. We know that patients who seize, they're at higher risk of causing intracranial pressure. They can have pressure gradient changes that can cause the aneurysm to re-rupture. And we know that ongoing and sustained hypertension also is probably setting the patient up to have a complication. Now, the guidelines are clear. And Sally, I really want to ask you, how are you thinking through what drugs to give when you think about hypertension and seizure prevention in this acute setting?
Yeah, absolutely. I think starting with blood pressure management, the first thing that there's a lot of debate about it, and sometimes I think honestly it's a blessing that we don't have a specific blood pressure goal, which makes you think that every patient requires that kind of individualized blood pressure goal. So, when we think about these patients, I think the first question that comes up is the aneurysm secured or not secured? Because that alone, can play a huge role for the blood pressure goal that you have. The patients that they don't have the aneurysm secured yet, the problem is that you are always afraid that if your blood pressure is even slightly high, you're going to rupture that. So usually those patients have a more tight blood pressure control goal. Every institution, I'm sure, is different. Sometimes we talk about less than 140, sometimes we talk about less than 120. But again, it's just important to note that these patients require a lower blood pressure goal. But then on the flip side, if you have a patient that requires more perfusion because they're at risk of infarction, those patients require augmentation of blood pressure. Obviously, at this point, the aneurysm is secured, and it's a little bit, down the road when we talk about that. So as far as what agents to use, I think we've had this discussion in other, episodes that you want something that is quick on, something that is easy to titrate. Agents that come into play are nicardipine, clofidipine. I would highly recommend that people stay away from long-acting or agents that are not easy to titrate. Even some IV agents, like labetalol, it's not easy to titrate. IV hydralazine, you could potentially get away with like 1 or 2 doses initially before your infusion is there, but it's not really your ultimate blood pressure medication to use. So, and lastly, I think when it comes to blood pressure, the guidelines really focused on minimizing blood pressure variability. So more than really what goal to target, just avoiding these fluctuations is our ultimate goal, with the idea that every patient should have their own specific individualized goal. As far as anti-seizure medications for seizure prophylaxis, I think previously a lot of people focused on 7 days for seizure prophylaxis, or maybe until your aneurysm is secured. But then there was more evidence after that kind of statement that we don't really have enough information or evidence to back that up. So maybe that was just something that was recommended without much evidence behind it. The new guidelines, I think, really are focusing on who is at risk and targeting those patients. And I really like how they specifically said, patients who have MCA aneurysm, patients who have high-grade aneurysmal subarachnoid hemorrhage, meaning Huntington has a greater than 3 or Fisher greater than 3 or 4, people with cortical infarction, people with hydrocephalus, just like you mentioned, that are at high risk of just worse outcomes in general. Maybe those patients should receive it. They do talk about the fact that we don't know what agent to use, but stay away from phenytoin because we know that phenytoin is associated with worse outcomes. Another additional pearl is that phenytoin will interact with nimodipine and it will drop the concentration of nimodipine, which you do not want that. So there's a lot of reasons really not to do phenytoin. Levetiracetam is a good option. If you don't want to do that, I think lacosamide could be another good alternative, which is a newer drug, minimized drug-drug interactions and things like that. And then there's always this question of, okay, I have this really high-risk patient with hydrocephalus, Huntington has a 4. How long should I keep this anti-seizure medication for prophylaxis? The real answer is that we don't know, but the guidelines say that, they kind of talked about studies looking at 3 days or less and 3 days and more. And guess what? The outcomes for preventing seizures in the hospital was the same, but people who received it for a longer duration actually had worse clinical outcomes at the end in long term. So I think there's still probably more, I don't want to say evidence, but probably it looks like it's more favorable to use the shorter duration of seizure prophylaxis. But the actual true duration of seizure prophylaxis, is not exactly or 100% known.
Absolutely. So just to emphasize, we don't have an exact target for blood pressure. We want smooth lowering of the blood pressure in our patients who are not secured. Using those titratable agents. Again, we know hypotension is bad for our patients. And then there's still a lot of equipoise about how long to treat with seizures, but certainly avoiding phenytoin and then trying to get away with the least amount of seizure medication possible. I think what I really liked about these guidelines is that they really tried to emphasize look at the patient in front of you. The grade 1 subarach probably does not need to be on a whole week of seizure prophylaxis. However, the high grade patient who you don't have a great exam for, and you're maybe seeing that they've got some IIC variability, they're being monitored, that patient maybe is a totally different patient than the low grade subarach. The other thing that was different from these guidelines is TXA. So Salia, walk us through like what happened with TXA.
Absolutely. As you said, this is a change. So previously, I think there was a lot of maybe interest, and guidelines made it sound like previous guidelines made it sound like it's reasonable to give TXA, to prevent rebleeding, especially if you're going to be in an institution that you can't treat that, aneurysmal SAH immediately. And I think one trial came out that made this really made this new recommendation. And then even after the guidelines got published, there is another study that was published in Brazil that I'm going to talk about. That also, I think, make things even easier to and more clear to understand. So the Ultra trial came out and they showed that if you actually treated that aneurysm within average time of 14 hours, giving antifibrinolytics such as TXA did not help with outcomes. But then they kind of put it out there that, okay, like if you're in an institution that you can't act on it immediately, meaning you can't treat this aneurysm immediately, maybe there's a role. But then May of this year in Brazil, there was a study that was published and they showed that even in centers that they're not treating their aneurysms quickly, I think the average time for neuro-IR procedures was about 3 to 4 days, which is pretty late. They also not only showed that this was not better, there was higher mortality with TXA. So I think right now the new guidelines are saying we do not recommend this. So I think TXA is out. So I think that's just something that is different. Obviously, it's not benign. There's a risk of thrombosis. There's all these other conditions that can happen with TX and other agents in that category, in that class, such as aminocaproic acid. So just reinforcing the guideline recommendation that there is no real benefit for giving these agents.
I love that. We're just moving towards being like Zintensivists. So I think we've kind of covered everything. I mean, really, when a patient comes in, you have a high level of suspicion, worst headache of life, needs a head CT. Can be pretty confident within 6 hours of ictus that if the head CT is negative and you have a good scanner and a neuroradiology reading it, you're good. Otherwise, you need to go down a diagnostic algorithm to make sure you're not missing it. And that really does include the LP. We're thinking about treatment of, or first of all, triage to an appropriate center and really using medication wisely to prevent, re-rupture, to treat and prophylax against seizures, and then to get somewhere into a place where they can get an EVD, but TXA, not so much part of the guidelines. So this was a really, really fun part one. And then I hope you'll stick around. In the next episode, we're going to cover sort of what do you do when these very complicated and super interesting patients land in the neuro ICU? Salia, any last words?
No, I think you covered it all. We'll see you in the next episode.
All right. Bye.
Bye.